Bismillahirrahmanirrahim. The next topic of our discussion is H. pylori gastritis and peptic ulcer disease. So H. pylori, also known as Helicobacter pylori, is a spiral-shaped bacillus bacteria which infects the stomach, causing gastritis, and in later stages resulting in peptic ulcer disease. H. pylori infection can cause acute gastritis as well as chronic gastritis. Chronic gastritis in severe cases can progress into formation of ulcers in the stomach and duodenum. So Helicobacter pylori is a spiral-shaped bacillus bacteria and it is gram-negative. The bacteria are motile due to presence of flagella and they are mostly acquired through either fecal-oral route or oro-oral route. The only host for Helicobacter pylori is human being. So H. pylori results in acute and chronic gastritis, formation of duodenal ulcer, and formation of gastric ulcer. So let's understand the pathogenesis of gastritis. Since these bacteria are motile due to presence of flagella, once the bacteria are acquired, they reach the stomach and they move down below the mucus layer and remain buried there. Below the mucus layer, the bacteria attaches itself to the gastric epithelium. The H. pylori exhibits a specific adhesion molecule on its surface, which is known as BAB-A. And this adhesion molecule attaches to the epithelium at another antigen exhibited on the epithelial surface, known as Lewis B antigen. This adhesion of the bacteria to the epithelium initiates an inflammatory process, resulting in the recruitment of the inflammatory cells causing gastritis. Gastritis could be either acute or it could be chronic. The acute gastritis usually goes unnoticed, but chronic gastritis becomes significant due to severity of its symptoms. So one question arises here that how these bacteria pass through the acidic environment. The first thing is that the bacteria buries itself below the mucus layer where the pH is already lower than the stomach lumen. Moreover, the bacteria also secretes a specific enzyme known as urease enzyme. This urease enzyme disintegrates the endogenous urea into ammonia and carbon dioxide. This ammonia is basic, hence the presence of base in an acidic environment elevates the pH, shifting it from acidic side to alkalic side. So the pH becomes elevated, which makes the circumstances favorable for the bacterial growth and replication. Helicobacter pylori also results in an increased production of acid. So H. pylori affects the G cells and D cells. The G cells produce gastrin. This gastrin stimulates the chief cells, resulting in increased production of the hydrochloric acid. Moreover, H. pylori bacteria also affects the D cells, resulting in decreased somatostatin. Somatostatin normally inhibits the acid secretion. So there is decreased somatostatin, hence resulting in loss of negative feedback mechanism, and there is excessively increased acid secretion. This increased acid is drained into the duodenum, which results in the damage to duodenal epithelium. The continuous damage to duodenal epithelium results in the replacement of duodenal epithelium by the gastric epithelium. This replacement of the epithelium is known as metaplasia. H. pylori bacteria are exclusively for the gastric epithelium. They only and only attach to the gastric epithelium and damage only the gastric epithelium. So the metaplasia in the duodenum gives an opportunity to H. pylori bacteria to damage the duodenum as well. So these H. pylori attach to the gastric metaplastic epithelium in the duodenum, initiating an inflammatory response and formation of duodenal ulcer as well. So how are these ulcers actually formed? H. pylori bacteria is recovered from almost 100% cases of the duodenal ulcer and almost 90% cases of gastric ulcer. This formation of the ulcer is driven by the two genes. The first is CAG-A gene and the second is VAC-A gene. CAG-A gene produces a specific protein which is injected into the gastric epithelial cells, which through certain mechanisms induces the apoptosis of the gastric epithelial cells. Moreover, the VAC-A gene produces a specific protein which increases the cell permeability, suppresses the immune activity in the area, and also induces the apoptosis. It also inhibits the regeneration of the cells. Hence, there is a loss of balance between the cell death and cell regeneration. This imbalance ultimately leads to formation of a gastric ulcer, or if it is occurring in the duodenum, it results in the formation of duodenal ulcer. So let's go through a quick recap about the pathogenesis. In the pathogenesis section, we have discussed about the mechanism of the gastritis, the mechanism of increased acid production, the mechanism of duodenal ulcer, and the mechanism of the gastric ulcer. So all these four outcomes are due to H. pylori bacteria. Coming on towards the morphology, H. pylori is a gram-negative bacteria and exhibiting flagella. It can be demonstrated on the biopsy specimens. The biopsy specimens also reveal the presence of neutrophils in the lamina propria and intraepithelial areas. Moreover, the plasma cells are also present in the subepithelium. The presence of intraepithelial neutrophils and subepithelial plasma cells is a hallmark of H. pylori gastritis. As you can see here, these are the inflammatory cells present in the intraepithelium as well as in the subepithelium of the stomach. In severe cases, there is atrophy of the gastric mucosa. One thing to remember here is that the disease most commonly affects the antrum of the stomach, since there is decreased acid activity in the antrum. In severe cases of the disease, there is diffused atrophy of the gastric mucosa, which is replaced or covered by the carpet of bacteria. Lymphoid aggregates are also present with the germinal centers. The germinal centers refer to the production site of the lymphocytes. So these lymphoid aggregates are known as MALT or mucosa-induced lymphoid tissues. Lymphoid tissue has a strong tendency to transform into lymphoma. Moreover, the H. pylori bacteria also increases the risk of gastric carcinoma. Acute gastritis usually goes unnoticed, but chronic gastritis presents with the recurrent abdominal pain, which has three particular characters. The first is localization to epigastrium. The second is that the abdominal pain is not constant, rather it is episodic in nature. And the third point is that these episodes of the pain are associated with the food intake somehow. The patient also complains of acidity and burning sensation in the stomach. If acidity is occurring while the stomach is empty, in most cases it refers to the duodenal ulcer. And if acidity is occurring after the food intake, it is related to stomach ulcer. There is often bleeding from the ulcers, resulting in hematemesis in almost 40% of the cases. And tarry black stool indicates a bleeding ulcer. The patient might also have anorexia and nausea. The diagnosis of peptic ulcer is based on the endoscopy, whereas H. pylori bacteria can be detected by carbon-13 urea breath test. In this test, a patient is given a dose of urea which is laced with carbon-13. The urease produced by the H. pylori bacteria converts this urea into ammonia and carbon dioxide. This carbon dioxide, since it is formed from the urea C13, it also contains carbon-13. This carbon-13 is detected by the spectrometer. The more easy, specific and sensitive test for detection of H. pylori infection is detection of H. pylori fecal antigen, whereas the gold standard diagnostic test for H. pylori is culture of the bacteria, which reveals gram-negative, spiral-shaped, motile and urease-positive bacteria. A bleeding ulcer constitutes an emergency which can further progress into gastric or duodenal perforation, which can result in either hypovolemic shock due to bleeding, or it can also result in acute peritonitis. A biopsy specimen is also taken during endoscopy to evaluate dysplasia and cellular assessment for the formation of tumor. The treatment of H. pylori gastritis is with proton pump inhibitors and antibiotics. A triple regimen or quadruple regimen which includes proton pump inhibitors and antibiotics, mostly amoxicillin, clarithromycin, metronidazole, and often rifabutin, are usually used to eradicate H. pylori bacteria. So this brings us to the end of discussion about H. pylori gastritis and peptic ulcer disease. If you have any questions, do let us know in the comment section. Thank you.